Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome to the Glasses Half Full podcast. We have Patrick again, who got out of the basement.
Release them temporarily.
We might let you go after this one.
Depending how he does.
Yeah.
Might hold a little longer.
Um,
I still need to change.
God, in 3 weeks.
Yeah, tell me about
Got some links.
it.
So, okay, today I think we've covered the cataract part and the clinical part of that quite.
Yeah, watch our previous episodes. Not that you're watching them all anyway.
100%. I think this one, we can delve into more a bit about the IP part of your certificate, because you're IP certified, obviously. And a lot of optoms, I think I say the majority of optoms aren't IP certified.
Oh, really? Out there, estimate there. Really brave on that estimate. What made you? What made you want to be IP anyway? Or is that something that came with the job? Or
I mean, yeah, I kind of just like, it was a natural progression into IP because of the job. I think if I was locuming or if I was in a normal like resident position, I'm not sure. Well, I know I wouldn't have done it.
Yeah.
I think for me, I was pushed that way because of what I was doing. It's easier, and do you know what? It gives you. Yes, you have company guidelines, and yes, everything is done under a surgeon, and you can always refer back. But it just gives you that little bit of extra confidence in what you're doing.
Yeah.
You're like, actually, I can make a decision on this now.
Fair enough.
Yeah.
How difficult did you find getting the certification? In comparison to university and pre-reg, how difficult would you rate it on that kind of scale?
I mean, the academic side is more just tedious than anything else.
Yeah.
It's just like, oh, why have I done this? It's like I've already suffered 2 degrees. Why am I doing
it
this?
sounds like you've just been studying for the last 20 years.
Honestly, that's what I said to, because I've done it with an ex-colleague of mine, and we were both like, why have we done this? But it was, for me, my wife was pregnant at the time, so I was like, I'm going to do this before the baby's born, and I've got a screaming kid at home. But it just, in terms of difficulty, it's more, you've just got to knuckle down and do it.
Yeah.
And you've got coursework to do, so you have to do an essay on, you have a patient with anterior uveitis, talk about this. You have to imagine the patient's attended your clinic and what symptoms they're showing, what signs they're showing, what you prescribed them, why you prescribed it, what might contraindicate with the drug that you've prescribed.
Yeah.
It's just all that kind of, and you have every.
Imagine writing an essay.
I know this is the thing; it's rough because you're taking yourself back. But I'm so glad I did it now, as we all are, just purely getting degrees out of the way. But yeah, it's just tedious, but it's worth it. And you've got like MCQs every so often.
Yeah.
So you'll have multiple choice exams. You have some written exams which are a bit more difficult.
Yeah.
And then we had a final exam with the college. That was quite difficult, but again, well, yeah, but it was done remotely, so the whole course was done remote.
Was that COVID?
No, yeah, I think it came through COVID and then it kind of stuck because I did it with GCU, so Glasgow, Caledonian, so it's not realistic for me to be traveling up there. Yeah, so yeah, it's moderately difficult, but it's like anything else in life. If you want something, you just got to knuckle down and do it. And that apparently, my friend who was also my previous supervisor, he's doing it now.
Okay.
He actually got a grant through local CCG to do it.
Oh.
So he's been
Happy days.
Yeah, happy days. But he said to me now that you don't actually have to do the final exam with the college.
Okay.
Which is nice. It's built into the course.
Yeah.
Because there's that extra stress at the end, like if I don't pass this within this amount of time, I've then got to do it all again.
Yeah.
Correct me if I'm wrong, but is there not also a required amount of clinical time that you have to do?
Yeah, so that's also the difficult part. In fact, probably that's the most difficult part in terms of completing it, is getting a placement.
Yeah.
Because you've got to write to a hospital, have a consultant accept you, and then you've got to go and shadow so many cases, and then write upon them. I think you've got to do like 24 sessions or something like that, 24 episodes.
So who are you like contacting? Is it the hospital or is it like the office?
Well, in my position, I don't know, because I did my placement through my place of work. So I kind of
skip that a little bit.
Yeah, so that's why it made even more sense for me to do it, because I thought I've got an opportunity here to not mess about trying to get into a hospital. One of the ophthalmologists within the business can sign me off. So for me, my case episodes were post-ops, and then the surgeon was signing it, so I boxed it off pretty quick. But from other IP optoms, what I've heard is it's taken them months, if not years, to do that part.
Is there no time constraint on it, is there?
I think there is. I think it's something like 2 years post.
And you have to repeat something.
Yeah, it's like same with optom. You have to do it in a certain time period. Yeah.
Would might be a long shot, but the ophthalmologists that you worked with at OE, would they also supervise non-OE optometrists?
Good question.
Or is that up to their digression?
Yeah, exactly. I imagine it would be.
It's another option.
It's an option, mate. Yeah, and do you know what I've learned in life is if you don't ask, you don't get.
Yeah.
So whenever you're unsure, just ask the question, and through that you might get an opportunity. Yeah, just ask.
How useful did you find that qualification through your work? Because I mean, with where you used to work or when you work now, I'm guessing it's used much more, especially now that you're going to probably deal with post-op.
Use it less or more now? Or do you not use it before, not use it now?
Oh, with the IP?
Yeah.
It's less, I'm not seeing them. It will be more. Yeah, it will be more, I think. Yeah. Because of my previous role, I was seeing a big bulk of just routine testing and contact lens appointments. Whereas this is, to be fair, I think actually the patients that are in my clinic as follow-ups will be problems. So the reason that they'll come back for a post-op with me as opposed to community post-op is because they've been triaged. Exactly. Yeah, so there will be a need to use it.
And how about, I'm talking more into like, because obviously a lot of people listening to this would be community optometrists. How useful do you think the IP qualification would be for them in their day-to-day?
Not very.
Not very?
No, because you don't get paid anymore for it.
No.
No one says, oh, we're going to employ you on a higher rate because you're IP. You actually, I'm proper like not doing anything for it here, but you're giving yourself more responsibility because you're classified as a higher level of optom. So if you miss something, are they potentially going to come down? I mean, don't quote me on that, but think about it logically. You're an IP optom. How did you miss that retinal detachment that you especially should be? You should be already like a further training. So it's difficult from that perspective. I think unless you're actually enrolled on some sort of scheme where you're on like a MEX accreditation or like you're doing a pairs clinic, then it becomes beneficial because then you can start claiming for stuff. Again, that's not my area of knowledge. I don't really know how that works. But I imagine if you're in a red eye clinic doing MEX all day, IP is going to be really useful. But as a generic like a refracting optom that's just seeing routine tests, then not very beneficial. But for the future, I think it will become beneficial. So I think even from that perspective, even if you did it and realised that actually it's not going to give me any more earning potential now, it's not always about that. It's about the future. Like, what is it going to come to a point where optoms have to have it? Potentially.
I think it's going that way, especially in Scotland. I think they're talking about implementing it to be integrated in university degrees as well.
Yeah, exactly. And I think places like Wales and Scotland are so much better set up for things.
They're more ahead.
We're so behind in England. Like, I know because my friend's got a practice in Wales, and like some of the stuff he tells me, like, so he gets like 60 quid for seeing a red eye appointment. Whereas here, I don't even know what we can claim. I just know it won't be 60 quid. but they encourage it more.
Yeah.
They encourage it more, whereas we don't seem to be on that yet.
You worked in something. You said like dilate every patient or something.
Or 60.
Yeah.
60.
Same as Scotland, yeah.
Even if there's absolutely no clinical need to. like you get like my pupils aren't that big, okay?
Yeah.
The people with pupils 3 times the size of mine that are getting dilated because of
Bang it in.
62.
Yeah.
Absolutely. Why not? Pop. They're expecting it.
Yeah.
And they think, I mean, for better, for worse, for better, they think that they've gotten a better treatment, even though there's nothing I couldn't have seen before that I saw with their 11 millimeter pupils, now 12 millimeters.
Yeah.
But they're happier because they feel they got a better
I
service.
think it's good as well. It's good to just do it because you never know what you might pick up.
Yeah, no, absolutely.
And how many times have you seen angle closure through tropicamide?
Once.
Have you seen it once? I would expect to say zero.
Yeah, no, I triggered it once as a pre-reg. And I was panicking.
Oh no!
Because
you're like, do ILPs before, do it afterwards.
As a pre-reg, you do like
you
everything,
do it all.
biblical on the dot, everything. And I kept calling the hospital because the pressure it wasn't like a proper.
Were they hypero?
I have no idea, but probably.
Yeah. That's traumatic.
Yeah, probably.
But, it was like they were like 17 before and like 37 after, and I was panicking. So I was on the phone to the hospital, doing all that, and they were so flippant about it. They could not care less. They were like, try again in an hour, and it was like, they're still like 34. Try again in an hour. It's like, okay, they're about 30 now. Yeah, they're going down. Send them home. I'm like, okay.
Was the patient in pain?
No.
There you go then.
Yeah, I mean, not the typical angle closure tag. No
So
pain.
how many times has that actually happened then? Probably quite a lot. We send them home and it goes up, but it's going to come down.
I mean, what was it? The highest likelihood is 50 minutes after the drops?
Yeah.
50 minutes after the drops. That patient's out of your clinic.
That's it.
Oh.
Yeah.
How would your management differ with the specific types of patients? I'm talking more on like if you were to see a certain case as an IP optometrist, what can you do to manage them with you instead of referring them? So what would you not refer and manage yourself as an IP?
So what you feel comfortable with. Yeah, I mean, with the IP qualification, you've got the autonomy to make that decision. Like if it's something generic like CMO or rebound uveitis or anything like that, I'd probably feel comfortable enough to manage it myself. But anything further than that, I might start thinking, is this outside my remit now? Because if you look on the college guidelines, for example, say like HSK, as an IP, you can manage that yourself.
Yeah.
Am I going to manage HSK by myself? Probably not, because I think I can't remember what it is exactly, but it says something like, if it's epithelial, that's it. If it's epithelial only, then Optom can manage. Yeah. But if there's some stromal involvement,
no thanks. I'm not being like,
that's what I mean. Man. If you see a dendritic ulcer on someone's eye, you go, oh yeah, it's like, it's epithelial. I'll sort this. Nah,
get out of here.
Nah, you're referring that.
Absolutely.
So, would it be all types of keratitis that you prefer, or is there some that you would actually be okay managing?
Maybe like some, Again, it's case by case. It's like, what are you seeing, and do you feel comfortable with it? I wouldn't categorically say I'm not doing that.
Yeah.
Because there was actually, funnily enough, someone that I did manage for HSK, but the patient was a GP, and it was a private patient.
That scared me more.
I didn't realise she was a GP until afterwards. So I sent her away with a prescription, and then she came back. She was like, "Oh, these pharmacies didn't have it, but I managed to contact this one, and they had an alternative in stock. If you could sign for that instead." I was like, "Right." Some patients like good. She's like, "Yeah, I'm a GP." I was like, "Oh." But with her, it was more that it was. It looked like it had like a bulb appearance, so it could have been dendritic, but realistically it was probably an abrasion that looked like it.
Yeah.
So therefore I was a bit more comfortable doing it.
Yeah.
And especially as I flagged it to the surgeon and then called her back in 24 hours.
Yeah.
Again, it just reverts back to what you're doing with them.
Fair enough.
Yeah. I'm just thinking about how I've had the misfortune to see a lot of uveitis in clinic.
Yeah.
I'm just thinking how currently or prior, just recognizing it. Yeah, a couple of flares. Yeah, it's uveitis. But imagining when it comes to you making that decision, it'd be a case of, okay, no, let's double check. Okay, let's triple check.
Worst case scenario, what's going to happen? You give them steroids.
Well, if there's not uveitis, then how?
Induce cataracts.
It's going to induce a cataract. You're going to have to be on steroids for a while, aren't they, for that? So yeah, it is a scary thought.
Yeah.
But you know, like when you're in these clinics and you just see like cells and flare on every patient because post-operatively you get inflammation. You kind of become less scared of it.
Okay.
It's almost like you guys seeing cataracts in clinic.
Yeah.
It just becomes
Just pedestrian. That's all.
yeah. But still not to like.
Of course, not to downplay.
Yeah.
Is there anything else that you'd probably?
I'm sure you're chucking chloramphenicol off the shelves.
Oh yeah, mate. Yeah, just do what GPs do. Die, chloramphenicol.
Literally.
Yeah, so like your conjunctivitis, your bacteria, but we can.
How about like angle closure? Would you still be referring that, or would you do pilocarpine?
You give them. I mean,
both.
Yeah, cyclopentolate and pilocarpine, but you'd still refer.
You still send them on their way.
You still refer that.
Jump the gun a little bit.
Yeah. I mean, like you can give extra things for dry eye. You can give steroids for dry eye. You can prescribe systemic oral medication for like your doxycycline for posterior blepharitis. So you can prescribe systemic drugs as well. So things that you take orally for stuff.
What was the one that Mark keeps mentioning for dryness that he likes to give? It begins with an S.
I'm sure, actually.
Accent's got an S in
it. Accent red.
No. Yeah.
Was it spironolactone? Is it that? That's not bad, is it?
Was it the
cyclosporine?
Cyclosporine, yeah. Oh God, so I'm not like a novice here, but I think it's something to that's like just a really expensive dry eye drop. I don't know how they do it. Yeah.
That's not something IP optometrists could.
We probably could.
Oh, okay.
Yeah.
Is there like a long list of things that you?
Yeah. It's not like I've got this list in my head of what I can do. Yeah. It's more.
What about the exciting stuff? The morphines, the testosterone. Like, is there anything that you could just like chuck under the table?
Yeah. Here's an EpiPen.
Any amphetamines?
Yeah. Nah, nothing exciting. Just some boring steroids.
Not the fun kind.
Yeah, not the fun kind. Yeah.
I would say like more of like a long list, and then I'm guessing it's just you see the patient, you figure out what's wrong, and you choose based on basically.
Check the guidelines, check the college guidelines, and then make a decision.
And then when you're prescribing, do you have like, is this something that you would make the hospital aware of managing yourself at all, or is it just if you can't do anything, just send them to the hospital?
Yeah.
How about letters to GP? Would you be sending that at all, like information?
Yeah. So the cool thing with Optegra is that once you've seen the patient, there's a page called correspondence. You click it, and then you choose who you want it to go to, and generally speaking, it goes to the optician that referred and to the patient's GP. Yeah.
So IP, isn't quite as useful in community or high street.
At the moment.
At the moment, until they eventually probably might become compulsory.
Probably might.
Probably. We'll see. We'll see. Do you feel that having IP helped you land Optegra? Or did they just ask for that?
I think so, yeah. I think that's like the gold standard.
Yeah.
I think in terms of recruitment, what they wanted was an IP optometrist that has done refractive.
So you just ticked all the boxes.
So I ticked the box, yeah. But then I don't think they wouldn't employ if I wasn't.
Yeah.
So if they couldn't get that, they'd then look at a refractive optometrist, and if they can't get that, then a community optometrist.
A runner. And if they can't get that, we've got 18 years with a runner.
Yeah.
Oh,
just an optical assistant that cannot refract.
Thank you very much for watching this episode. This is probably the last of this little mini series with Patrick.
Thank you very much for
it. It's fine, mate. Yeah,
I really appreciate that.
No problem.
If you want to come again and baby does not cause issues,
it's a nice break.
But yeah, thank you very much for joining us. Thank you guys for listening, and we'll catch you in the next one.